Hello guys, thank you. In this exactly moment, we have more than 2,000 people in the three channels, website, YouTube, and here. And your session, more than 3,000 people watching you. Thank you to be here with us. It's such a pleasure to be here. And let's moving on now the session 2. But before, I have a video for my friend for Ireland, Dr. Arthur. A question and a video for you, please. The question for the audience is, what technology are you looking forward to the most in the post-COVID era and why? Please, Arthur, your question for us, your answer.
Lyric, laser-induced refractive image change, which can non-invasively alter the refractive properties of the human cornea. This must be one of the most exciting technologies that any refractive surgeon can imagine. It really sounds like science fiction. Lyric can change the refractive power without changing the corneal shape or without changing the corneal thickness. And it has potential to work on an IOL-2, allowing one to fine-tune misrefractive target. Lyric is performed at a wavelength of 405 nanometers, which is at the blue end of the visible spectrum. At this wavelength, Lyric is a two-photon absorption process, resulting in highly localized refractive image changes. Within the laser focus volume, instead of removing or interrupting tissue, Lyric alters collagen fibril density. Lyric is relatively non-invasive, that it uses pulse energies that are 100 to 1,000 those used to create a 10% laser flap. This looks like the future. Why? Being able to improve vision without ablation, without cutting, without photo disruption.
Arthur, thank you. And now let's move on for the polling question. Please, Javi, the polling question. Okay, guys, here the polling question, please, about IOL premium. Please, you have 50 seconds to answer this question. The next session, all panelists and speakers and coordinators coming on. Please, Javi, let me show the results. Hello guys, number one, 59%, an IOL that is the 3 measured target visual points. Okay guys, please, the session video to introduction this great team that you start now, and thank you again to be here. Hello Kathleen, Ivo, Laureano. Let's go to start the video.
Premium IOL's session. The coordinators. Ronald Krueger and Ashraf Armia. Guest panelist, Ivo Ferreira, Uruguay. Featuring speakers, Cathleen McCabe, USA. Florian Krebs, Germany. Laureano Rementeria, Spain. And Sheraz Daya, UK. Organizers: Sergio Canabrava, Brazil, and Ashwin Agarwal, India.
Hello everyone, and I am happy to be here in this great webinar. I'm so pleased to coordinate this session with Ron and Ivo. It's our pleasure. Thanks for the great work of Ashwin and Sergio to make this session great. Is Kathy with us?
I'm here.
Yeah, hi Kathy, how are you?
Hi.
It's our pleasure. So we are going to introduce Cassie, one of the biggest surgeons all over the world and one of the eminent in premium cataract surgery. She's going to talk about the new Alcon EDOF lens, the Vivity and the Panoptix. Here, Kathy, how are you?
Thank you very much. And this has been such a wonderful meeting so far. I want to congratulate Ash and Sergio and everybody. I've learned so much already and already taking great notes. So I'm going to talk to you today about the Vivity, which is a new EDOF lens, and the Panoptix, an advanced trifocal that we just recently got in the United States. So everybody wants premium outcomes for our cataract patients. And in this new normal, it's even more important for us to have independence, both for our patients and for providers. Vivity, which is an EDOF with a monofocal-like visual disturbance profile that does not split light and is an available solution for patients who are not ideal candidates for trifocals, and the Panoptix, which is an advanced trifocal with excellent distance, intermediate, and near vision, are both great solutions to make this happen. So if you ask surgeons, why don't you implant a presbyopia-correcting lens? The most common reason will be visual disturbance complaints from patients that we're trying to avoid. So that's where Vivity comes in. It's a new extended range of vision monofocal lens. You can see it here. It has a very subtle optical element in the center of the lens that provides an extended range of vision. It has a visual disturbance profile that's comparable to the monofocal aspheric SN60WF. And meanwhile, mesopic contrast sensitivity is preserved. So here is a diagram on the right where you can see that central 2.2 millimeter wavefront optic. What it does is stretch the wavefront in front of it and behind the retina, and it shifts the hyperopic side to the myopic side. So in doing so, it also avoids light splitting, which is why you get such a wonderful visual disturbance profile. So if you look at the light intensity distribution for a monofocal lens, you get sort of this focal point at distance. And a diffractive EDOF lens will have a light intensity dip here in the middle. But with this wavefront shaping technology, you get more continuous extended focal range with light intensity distribution. So I was part of the pivotal clinical trial data for the FDA from the US study, and there was a parallel OUS study that was performed. And the binocular defocus curves from those studies showed this improvement in the intermediate and near range for this Vivity lens. And you can see excellent distance vision was preserved, but improvement both at the 60 centimeter and 40 centimeter distances. And then if you distance correct, you still maintain those differences. So it wasn't a mini monovision type situation. And this is really the key point for this lens. It has a visual disturbance profile that's similar to the monofocal lens. And if you see on the right, you'll see that actually numerically, and this was borne out in all the studies and in our site study as well, numerically, it was actually better than the monofocal lens for starburst and glare, and halo is about the same. So it was interesting, you know, if our reason for not putting in a premium lens in a patient was some sort of compromise is that you don't want to split light, and you don't want to have unwanted visual disturbances, with this data, it's hard to make an argument for not using a Vivity in those cases. So the Vivity gives distance, intermediate, and functional near, not as good near as a trifocal lens. It has a monofocal-like visual disturbance profile, or maybe numerically even better in starburst and glare. And it does this with wavefront shaping technology that stretches and shifts the wavefront. So let's talk about patients who really want independence from their near vision. We have Panoptix, and the reason it's an advanced trifocal is because the intermediate is actually at 60 centimeters rather than the normal 80 centimeters. And 60 centimeters is a more usable distance for intermediate vision. It's actually what OSHA says you should put your laptop or your desktop monitor should be at 60 centimeters for most comfortable use of your monitor. So 88% of the light energy is transmitted. It has a 4.5 millimeter central optic. 50% of the light is distance, and then the remainder is split equally between intermediate and near. And look at this binocular defocus curve, just a nice flat curve where you get quality of vision at all distances. Really a big difference when you compare it with the monofocal lens, big improvement in intermediate and near. The visual disturbance profile is different than a monofocal, so that's the difference with Vivity. Get better near, but you do have to have a discussion with patients that they may see some halos and glare at night. But overall, great satisfaction with this lens. 99.2% would have the same lens again. So in my hands, future premium lens offerings for visual independence are going to be either Panoptix bilaterally for patients with healthy eyes who are able to tolerate a potential for visual disturbances at night, especially who desire independent near vision. If they're compromised in any way, not an ideal candidate for a trifocal lens, they have pathology, they just won't tolerate visual disturbances, great, we have Vivity, which will give them a monofocal-like visual disturbance profile with an improved range of vision. Or what I'm holding out for some of my patients they have a healthy eye on one side, not so healthy on the other, maybe something I'm a little bit concerned about in the future, maybe Vivity in that eye, a Panoptix in their healthy eye, or maybe mini monovision with Vivity to improve their near. So I want to thank everybody, and thanks for including me in this wonderful panel, and what a fabulous meeting. Congratulations, Sergio and Ash.
Hi, Ron.
So our next speaker is going to be Ashraf Armia, who's going to talk about bioptics and pinhole pupilloplasty.
Thank you, Ron. Do you see my screen, yeah?
Yes, your screen's on.
Okay. So when I talk about this topic, I usually do the toric for most of my cases, but I came to this idea maybe since 6 months that I'm using two refractive type, the pupilloplasty and the bioptics. The idea came to me. I have to give the credit to Ashraf and Ferreira for this pinhole pupilloplasty. This patient came to me. She is a female Syrian, age 36, for a refractive correction for her right eye. On examination of the right eye, I found that she had an iris glaucoma about 3 o'clock hours with normal posterior segment. Her psychophagic reflection was +7 sphere, -5 cylinder, and with best corrected visual acuity was 0.4 with +6 sphere and 4.5 cylinder. Her left eye was perfect with no significant error, so I asked for a pentacam for a femto laser correction. When I have the pentacam, I was not happy with this pentacam. The steepening of the cornea was not, I didn't like it. It's more steep in the upper and less in the lower. I didn't feel it okay. When I look to the other parameters in the pentacam, I'm not happy, and also there is some posterior elevation. So I told the patient that I don't want to do a cornea refractive surgery. We are going to do another way of correction of the refraction. So my decision was a toric IOL, which is the high toric, with pinhole pupilloplasty as a premium refractive correction. This is the procedure. As you know, all known in iris glaucoma, the zooms are not easy going. So I opened the rexus, the capsule with the needle first. And the most important in these cases that you do a good central rexus, which is very important in toric IOLs, not too large and not too small rexus, but you should care that you do it in the right central way. After you finish, this is a soft lens. Usually you inject the inhalon, and I usually use the CTR in these high toric lenses, and also in iris glaucoma. I have some struggle in the CTR, but I put it, but I move it inside the bag, as you see, away from the area of the zonular. I marked the corneal astigmatism, and I put the lens. The most important also in these cases, when you do pupilloplasty, you must remove the viscoelastic behind the IOL, because you are going to close the pupil. I injected pilocarpine to close the iris. Very important, I'm going to stop here. Very important when you start doing this. This is the normal pupil. And this is the end of this, and this is the end, and this is the colobone. So when you take the first bite, you should start at this point and this point, because this is the first and most important suture you are going to do, because to have a good size rounded central pupil. Very important. I use the 4-through pupilloplasty, which is my technique now since many years, to close it. You have a good size of the pupil, and I take 2 to 3 another iris suture to close all the coloboma. And after you finish, you move to your viscoelastic, and you continue. You have a well-centered pupil. Surprisingly, post-operatively, this is what I was before the operation and the correction of the patient. But surprisingly, I found that the best corrected visual acuity of the patient became 0.8 with plus 0.25 sphere and minus 5.5 cylinder, which is improving due to this idea, because the idea of the technique is performing pinhole pupilleplasty helps filter the stray light from the periphery of the cornea in cases of high order corneal aberration. It blocks the distorted and unfocused light, reducing the aberration and enhancing the visual acuity and its image quality. The pinhole devices mitigate the impact of corneal abrasion and also improve the visual acuity of the patient. So my home take message in these cases, what I'm usually doing a lot, especially in post-keratoplasty procedures or high intractable corneal astigmatism, achieving the pinhole effect by narrowing down the pupil size. The pinhole pupilleplasty significantly improve the visual acuity in patients with high order corneal abrasions by allowing the passage of the light through the central pinhole area, but also take care that the Purkinje image is a useful step helping to locate and create a central pupil. Thank you so much.
Okay, thank you, Ashraf. We're next going to go on to the next speaker. Dr. Rementeria is going to speak a little bit about astigmatism with toric IOLs.
Okay. Good afternoon. And let me share my screen. Okay. So good afternoon, and thanks, Dr. Calabrava and Dr. Armina, for your kind invitation. It's an honor for me to be here. So did you know that according to the American Society of Cataract and Refractive Surgery in 2018 survey, 95% of participants believe that clinical significant astigmatism should be corrected. And yet, only 20% of these astigmatic patients receive a toric IOL. And in Europe, it's even worse. Only 11% of these astigmatic patients receive a toric IOL. How can it be? After this presentation, I want you to see and treat more and more patients. I want you to feel confident managing astigmatism, and I want you to know that trifocal and trifocal toric IOLs, when they are well implanted, are the same. They are exactly the same. Here we have the three main topics that we are going to talk about. First, the demographic distribution of astigmatism. Second, what we do and what we use in our practice. And third, the evidence-based medicine results. Here we have the demographic distribution of astigmatism. As you can see, 36% of patients have astigmatism between 0.25 and 0.75 diopters. But look at this. 70% of patients have astigmatism between 0.50 and 3 diopters. That is treatable astigmatism. What we use in our practice is these two trifocal toric IOL platforms. One is Panoptix from Alcon, and the other one is Ray 1 from Ferreira. Both are diffractive, and the biggest difference between these is the intermediate addition. In Panoptix, you have 2.17 diopters, and in Ray 1, 1.75. The light distribution, spherical and torical range are very similar. Another thing that we can use to correct astigmatism is these two IOLs implanted in piggyback. We have here a monofocal toric in the back IOL, and we are now implanting a trifocal in sulcus. So with these two IOLs implanted in piggyback, we can correct astigmatism and we can provide the trifocality to our patients. Another device that we use every day in our operating theater is this guidance system called Barium from Alcon. And the only thing that you have to do is to align the toric marks of the IOL with this big green line in the middle of the video. As you can see, the Barium, it's always following the eye movement, so it's easier for the surgeon. Here in number 3, we have the evidence-based medicine results. And this is a paper that we published in the Journal of Cataract and Refractive Surgery in November 2019. And we compare Panoptix and Panoptix toric. Toric IOLs were implanted in patients with 1 or more diopters of corneal astigmatism. Here we have the binocular defocus curves. And as you can see, from far to near, included intermediate, visions are really good. And both platforms are very similar. Here we have the binocular photopic contrasensitivity. And again, both platforms are very similar and the results are really good. Here, in difficulty in performing day-to-day activities, this graphic is represented in log scale. So the lower the graphic, the better the vision. We have in items like number 6, seen to walk on uneven surfaces, they are not similar, they are the same. And also in items like number 4. In the rest of items, the difference between these two platforms are very, very low. So before I finish, let me summarize. You know now that over 70% of patients have treatable astigmatism. You know now that it's easy to manage if you use the correct devices. And with the evidence-based medicine results, you can be relaxed. So with all those patients out there having astigmatism who wants to be treated, I want you to see and treat more and more patients. Now you know that it's easy to manage, so I want you to feel confident managing astigmatism. And with the evidence-based medicine results, you know now that trifocal and trifocal toric IOLs, when they are well implanted, are the same. They are exactly the same. Thank you, doctors, for your invitation, and thank you very much for your attention. Thank you.
Thank you, Romero.
Okay, thank you, Dr. Rementeria. Ashraf, any comment?
No, not yet. We'll take my dearest Sheraz. Hi, Sheraz. You finished your other part, and welcome here again.
Okay.
Sheraz is going to give a talk about the Artis Symbiose lens mix and match by design.
Okay, great. Well, thanks very much for inviting me to participate in this all-star cast of refractive and cataract surgery, in particular premium IOLs. It gives me great joy to talk about the Artis Symbiose lens, which is a lens from France, and I've called this mix and match by design because that's how it's been promoted. I'd like to acknowledge my wife, Marcela, and our technicians for putting the data together. These are my financial declarations. I am a consultant for Crystal Lens, who manufacture the lens, and I'll also be speaking about something from Barcelona. So when we're looking at trifocal lenses, as you've heard, the intermediate is the issue that we're trying to address. In spite of that, these are a series of different trifocal lenses. You still have a bit of a dip in the intermediate range. And the question is, how does one address this? And this is the Artis Symbiose lens. I'm not going to go through all the details, but they are different. There's one lens which is a mid, they're both trifocal. One is geared towards mid distance, and the other is called a plus for near. And they have different numbers of rings. And the intermediate lens is placed in the dominant eye, and the near lens in the non-dominant eye. And this basically works on a concept of continuous phase. So when you take a look at the point spread function, and you transform it to do a Fourier transform, you get the optical transfer function, and you break that down further, you have the MTF, and you also have phase transfer function. And where there's where the phase is negative, there's a visual degradation. And this is from Thibos's paper showing phase inversion and what it can do to an image in an eye with optical aberrations. Now with continuous phase, this is an S, a simulated S with phase inversion, and this is when phase has been corrected. So when it's been corrected, you actually see the S. You do have some other images around it from the other optical components. And the goal here is to eliminate this dip that we see in trifocal lenses, which causes a problem for the image. Now, patients do neuroadapt, and they can see this, but it can be problematic, and it can take some time. So the combined lenses together, the goal is to give continuous vision right the way through, with emphasis for near in one and mid in the other. And this is simulation of what that looks like on modeling of a trifocal lens versus Symbiose. So we did a study to look at the influence of continuous phase on defocus and whether the two lenses differed in performance and whether they did indeed complement each other. And this is a 100-eye study, bilateral, in 50 patients. And as I say, we put the mid in the dominant eye and the plus in the non-dominant eye. And all the procedures were done using 1.8 mm incision and femtosecond lasers. You can see the lens going in right here. Viscoelastic is being removed, and you'll see it centering very well inside that nice round capsular rhexis. All patients who had astigmatism above, were 0.75 and above, were treated with limb relaxing incisions. At 6 weeks, we did the usual tests, including defocus and also contrast sensitivity. And this is the mean age group of 63 years. There were more females than males. This is the preoperative spherical equivalent and postoperatively, and also the astigmatism preoperatively and postoperatively. Looking at breaking them up into the two different lenses, you can see that they actually didn't differ too much in terms of preoperative refraction and outcome, nor did the cylinder. Looking at refractive outcomes, this is what was quite interesting. In the mid group, 92% were within half a diopter, which is really good. And in the plus group, 91% within half a diopter. So again, fairly equivalent. What's interesting though is in the mid group, this is the dominant eye, only 21% gain one line or more of vision. Whereas in the plus group, and remember we're talking about cataracts and refractive lens exchange, 45% gained one line or more, which is significant. The predictability was good in both cases, as I've already illustrated. And this is uncorrected distance visual acuity. The blue bars are the mid lens, and the plus bars are the orange bars are the plus lens. And you can see this, as you'd expect, distance vision is good in both and comparable in both. And when looking binocularly, they do even better, with 81% getting 20/20 vision at 6 weeks. Now, looking at near vision, you'd expect the plus to do better. There's the orange bars, and they did indeed had the slight edge. And binocularly, even better still. At 60 centimeters, now this is intermediate, you'd expect the mid to do better. That's the blue bars. And they didn't, which is surprising. The plus did better. And cumulatively, they did very, very well. And patients were very pleased. And they did even better at 80 centimeters. Again, both lenses were equivalent at 80 centimeters. And 95% saw 20/20 at 80 centimeters. This is the defocus curve of one patient showing the plus in red, the mid, and cumulatively, showing benefit there. Contrast sensitivity, and this is the plus, and this is the mid. So the mid has slightly better contrast sensitivity. These are defocus curves of the plus and the mid, and both eyes open. And you can see there was no real dip. There was a slight dip in the mid at minus 0.5, but overall the lenses seem to perform fairly equivalently. Any complications? 2 eyes had macular edema, and this improved with treatment. This is in one patient. There were no explantations. One was decentered, but the vision was 20/20 at all distances, so we didn't intervene. And 2 patients spontaneously reported a reduction in near vision from the eye, the dominant eye, which had the mid lens. So in conclusion, the continuous phase definitely improves. It flattens out. There are no dips on the lenses, and patients did not complain about intermediate vision at all, and they adapted very rapidly. Do the 2 lenses differ in performance? Yes, they seem to. The plus performed better at all distances. And do the 2 lenses complement each other? Well, there's no clear evidence that this is the case at 6 weeks. And the performance of the plus, we're now doing a study where we're putting the plus in both eyes, and we'll evaluate their defocus curves and contrast sensitivity. Thank you for your attention.
Okay, thank you, Sheraz. Just a quick question to you, Sheraz. When do you choose this lens selection compared to other multifocal scenarios?
Well, we do trifocal lenses in 95% of our patients. I don't do mini monovision and any other things. I like to keep my chair time as low as possible. So we do a lot of them. And we were doing this in a sort of audit study situation, and the lens power comes into it's a very finite range, unfortunately. They're going to expand it, and they brought a toric version out. I think it's coming out soon. So as that expands, I'll be using this lens more of the time. We've been using the Physio lens. The hydrophobic is also an excellent lens. And it'd be useful to compare the 2 lenses. And that's another project going forth. What I want to do is validate that what they said on the box really was the fact. And I've discovered something that's a bit different from the other investigators. So we're going down a different route, but it'd be very interesting to see what the outcome's like. Overall, adaptation is very good, and patients don't complain that much about halos and glare compared to the others. So they take to the lens very, very quickly, very, very satisfactorily.
And do you have any criteria as to who you would select for, say, a Physio lens versus this lens?
Not really. I think if they're intermediate activities, so if they're a music conductor, I'd probably favor this lens over the Physio. But that would be about the only difference, really. Okay. They're all very good lenses.
Very good.
Kathy, yes. Kathy, you have a question. Given Vivity, what would you advise in cases of chronic open-angle glaucoma for stable vision?
Yeah, I think that's exactly where Vivity fits perfectly is patients who have stable pathology. Maybe they have some drusen, but you don't know what's going to happen in the future. They have a small epiretinal membrane that's not right at the fovea, but you're worried that maybe that will degrade their quality of vision in the future. They have stable open angle glaucoma, you know, things where you think that maybe I would be concerned in the future. I see my patient back 5-10 years from now and regret that I put in a trifocal or a diffractive optic. Those are the perfect cases for Vivity, I believe.
And what about your pupil size when you choose the Vivity? You look for the pupil size?
For Vivity, and
Yes.
also for other multifocal lenses, I really don't look at pupil size too much. And really even with Panoptix, with that 4.5 millimeter diffractive optic now, I don't really think so much about pupil size. So I don't think that that's much of an issue. Really small pupils that are only where that 2.2 millimeter are getting a pinhole effect anyway. So yeah, I don't think that's an issue.
Can I make a comment?
Yes, sure.
You know, we evaluated pupil size before surgery and after surgery, and there was no correlation at all. Everybody got a smaller pupil after surgery, and the mean was 4.2 millimeters. A lot of it depends on how much the iris is hung up by the lens and how intumescent the lens might be in terms of the cataract. So I don't think I know there's no correlation at all between pre-op pupil size and post-op. So you're probably using information that should be disregarded preoperatively if you are using pupil size for the audience out there.
Very good point. There was a series of questions for Ashraf about the pinhole pupilloplasty. How do you actually do it? Does it affect visual field or dilated fundus exam? Why use a toric lens if you're using a pinhole pupil? Do you need that? What are some of the thoughts on that?
Yes, I usually, when I do the pupilloplasty, I don't go for more than 3 millimeter pupil size. I don't go for less than this because this 3 millimeter, it is the size that I can see the fundus very clearly, and also the posterior segment can work easily with the posterior segment biome. Why I used the toric IOL? Because the toric and the pinhole, because I wanted to have the best stability of the vision and the highest contrast sensitivity for the patient. Because if I'm going to leave the iris glaucoma in young patients and I'm going to do toric, there will be halos more than the normal lens of the normal patient. So I wanted to have a good size of the pupil to maintain the good depth of focus.
Okay. There was another question here for Cathleen about when doing the Vivity neutral in dominant eye, and do you do a slightly myopic endpoint in the non-dominant eye to achieve all distances, or is it just go for distance in both eyes?
Yeah, I actually think this is going to be where we head in the future. There was a small subgroup of the OUS study that they looked at that had at least a half a diopter difference in their refractive outcome. And those patients actually did have an expansion in their near vision. And I think that that's a really sweet spot. I think we just need studies that show that it doesn't change visual disturbance profile significantly. But I think that's going to be where the money is.
I think Ivo has a question. Ivo had a question. Ivo Ferreira has.
Hey, hi. Yes. First of all, to congratulate Sergio and Ashvin. I think they're making history here, and we're being part of history of history thanks to them. This is an amazing panel. Thank you, guys. I think it was amazing. We're learning, but there's 3 points I think they're very important here, looking into the future, right? The first one, Kathleen, you were talking about that sweet spot at 40 centimeters, right? Our patients are changing that reading distance because of laptops and smartphones. I would love to know what you think about that. The second thing, Laureano talking about astigmatism and patient satisfaction. I think this is key here, right? If we're looking to new technology as Vivity, is it patient satisfaction being measured the correct way? What do you guys think?
Yeah, I mean, I think you make a very good point about where is it that our patients want to see the best as technology changes and their lifestyle changes. And I think, that is one of the weak spots maybe of where, intermediate has been in the past, where we're looking a little too far out. and near a little too close. You know, there's something in that 40 to 60 centimeter range that's really where patients are spending their life. You know, one of the nice things now is I don't talk to patients so much about near versus intermediate. You know, I mean, I think we used to spend a lot of time really thinking about that, and we had some choices that only really served their needs in one of those two locations. But now we have things that give a little broad distance or broad visual acuity in that range of distance. And I think in the future, it just simplifies what we do as well. We know where they want to see.
Quick question. So, sorry, there was somebody asking about a mix and match between Panoptix and Vivity. Have you tried that?
I haven't yet because we don't have Vivity outside of the FDA trial yet, although it is FDA approved now. We should have had it maybe a little bit before, but COVID put the brakes on some early distribution of it. But certainly I have patients I am having wait because they have an eye that's compromised. They have an eye that's healthy. I think I'll put Panoptix in their healthy eye and Vivity in their more compromised eye and see how they work together. But it's going to be, you know, seeing how it goes and talking to the patients about the fact that this is a new approach, and I think it'll work, but we'll see.
Rementeria, you have a question. What do you normally use the duet technique with the monofocal in the bag and trifocal in the sulcus?
Okay, I use this technique. Is the trifocal in the sulcus is the Sulcoflex trifocal from Reiner. And I use this technique maybe in three situations. First one is when patients have had already a monofocal surgery with monofocal in the back and they now want trifocality. And the second one, maybe is if I am not 100% sure the patient will tolerate the trifocality. Because if we have to remove an IOL, it's easy to do when the IOL is implanted in the sulcus than when it's in the back. And the third one, it could be when I don't have, but it's not frequent, when I don't have enough power of the spherical torical power. I can do a mix with the power of the in the back and in the sulcus one, and we can obtain the power that we want. And
another question, why only 20% of the American, 11% of the European, of the astigmatic patients receive toric IOL?
Money.
Well, money, yeah. Money, yeah. There are three main reasons, but the first in America and in Europe, it's the cost to the patient. And I think that here we can do anything. Maybe we can talk with the industry, but it would be an uphill battle. And the second one reason was, the first is the money. The second one is not enough training. And I think that here we can do a lot of things. We can train our residents and we can do astigmatic webinar and all those things to make doctors feel confident managing astigmatism. And the third one was technology not available. But the first one is money. Yeah.
Okay. I think we have to close the session. Thank you, Ron. Thank you, Ivo, Sheraz, Rementeria, Kathy, and thanks for Ashfin and Sergi for all the heavy work behind the scene. Thank you so much. Thank you for being with us.
Thank you for being a fantastic panel. We look to the future.
Bye-bye.